we go. Good morning, everyone. I'm John from HTN, and welcome to this panel discussion today, where we will focus on Lord Darzi's report, taking a digital perspective from the review. And I'm really pleased to welcome a panel joining us today. We have Lee Rickles, the CIO and Director at Humber Teaching Hospitals NHS Foundation Trust, Dr. Andrew Jones, the Digital Transformation Leader at AWS, Tracy McClelland, the Chief Clinical Information Officer at Daedalus, and Dan Bunstone, a GP and Clinical Director at Warrington Innovation Network. So thank you to the panel for joining us today. So over the next hour, we will discuss Lord Darzi's report and what needs to be the focus to realise the ambitions highlighted and to address the challenges noted. We'll move on to discuss the greatest opportunities and how we can realise the full potential of digital, as well as discussing the role of digital in a move towards preventative and a preventative model of care, and discuss the role of digital in integrated care as well. So we've got a lot to cover. So just a couple of housekeeping things. If you have any questions, comments, or views that you would like to share, or let us know what's happening in your organisation, type anything into the chat and we'll try pick up those as we go, but we have time for a planned Q&A as well. And this session will be recorded and there will be a write-up made by the HTN team, so you can read or watch it back at a later date. So let's start with some wider introductions. If I could ask the panel to introduce themselves, have a wider introduction, and can I ask them the first question of what stood out to you in the report? And Tracy, could we start with you, please? Welcome to the webinar.
Thanks very much. Hi, I'm Tracy McClelland. I am the CCIO at Daedalus UK and I have a background as a haematology and oncology nurse for the last 28 years, both across the NHS and private sector in UK and Australia, and worked as a service manager in haematology and oncology for many years. I moved into digital 9 years ago and have been at Daedalus for the last 5.5 years. Daedalus is a global organisation based in Europe. We have solutions covering the whole continuum of care. In the UK and I, these include our EPRs, terminology server, data platforms, LIMS, and patient apps to support sharing the record directly with the patient and family, as well as solutions to support clinicians working offline and in the community. So, in relation to Darzi's report, what stood out to me, I'd say there were several big standouts for me. Obviously, the drive to move care more into the community is the biggest standout, which we know has been a goal for some time across the NHS. And Darzi very clearly highlighted that this has not been as effective as had been hoped over the last decade. And he shared some stats that I thought were really stark around patient flow in the acute hospital trusts, with 7% fewer outpatient appointments per consultant, 12% less surgical activity, and 18% less activity for each clinician working in ED. And Darzi put this down to an underinvestment and patients no longer flowing through hospitals as they should. And for me, this was really stark, given the fact that we've invested so much as a country into digital recently. And I think that is somewhat the result of the lack of integrated solutions throughout hospitals and outside of hospitals, resulting in the patient data within those solutions being unavailable to clinical teams at the point of care, with communications to and from patients also being relatively poor because of the lack of that open standards and data being able to be shared easily between solutions. So the information being poor, delayed, or incorrect. And for me, open standards in EPRs and all other healthcare solutions can overcome this to a degree. Also with the support of health information exchanges such as data platforms and terminology servers, with patient apps and access for the patient to have the information being really, really central. So that, I think, would be my biggest takeaway and my biggest standout.
Fantastic. Thank you, Tracy. Lee, can I come to you next, please? Wider introduction and what stood out to you?
Yeah, thanks, John. So I'm Lee Rickles. I'm the Chief Information Officer at Humber Teaching NHS Foundation Trust. Just in the position of changing EPRs literally at this point in time, which is an exciting experience that you only really want to do once in a generation, if ever at all. I'm also the Yorkshire Number Care Record Programme Director, cover 3 ICSs, and it is around that sharing of information. So points that are clearly identified in the Darzi report of where information is not shared, we're still very siloed based. I've seen from that experience the high investment in the acutes, which doesn't happen in other areas. I also the director for Interweave, which is a NHS organisation that provides shared care record technology to 6-ish. I say 6-ish because it's not always an ICS. ICSs across the country. Also, I'm technical lead for the Yorkshire and Humber SDE. And I take a mental health lead in my ICS. So I know it sounds like a lot there. I just work some really good people and some really good teams and end up with a few different hats. The standout for Darzi, I think the key bit is we've brought Darzi in. He's very well respected. He's taken a very honest view of the NHS as it stands, whether that's the infrastructure, the staff, the recruitment and retention, the need to use technologies. In some ways, it's not massively different from the 2008 document. For those although there's some slightly different formatting, colouring, the tilt to technology and the left shift. And the patient voice are probably my standouts. The patient voice has always been my standout. The patient is the customer. The patient is the core. It's the patient that actually funds this service, and they're the ones that generally end up becoming the worst possible outcomes, because we don't really look at the patient as a person, hence patient, and look at the overall social determinants for health and how health is impacted by them. We generally find it's just that person, and we treat them and they go through that sausage machine. People may disagree with me, but anybody who's had to deal with having referrals into hospitals or to multiple departments and how they don't talk to each other, and that's within a hospital that has an EPR that doesn't even talk to itself, let alone across the wider system. So patient voice from our point of view is massively important. The tilt to technology, I think isn't that clear. I think that was a standout because I think it would have been helpful to have a direction of, are we an organisation that uses digital, or are we a digital organisation? So are we going to go the way of banking, and we're just going to take all them branches away and take all them bank places away, and we're going to do it all in that direction? Very brave government to choose that one. Or how we're just going to use technology effectively, where you've got like the lean approach or total Toyota production system, because technology is a key approach, but not necessarily the only one. Left shift, it makes absolute sense. Most care should be around the patient and around home. We've directed it through to the acute for a number of reasons. A lot of that is down to disinvestment in the left shift areas. It'd be good to recover that, but that's a 10-year journey to recover the 10 years of underinvestment. So they're the three standouts for me, John.
Excellent. Thank you, Lee. And Andrew, can I come to you next, please? Same question, introduction, and what stood out to you?
Sure. Good morning, everyone. My name is Dr. Andrew Jones. I'm the head of digital transformation at Amazon Web Services. So I'm a clinician by background, having spent time in both hospital medicine and general practice. I've been in health technology now for 20 or so years in a variety of different roles, including the BMJ and DXC technology. My role at AWS is really to help people understand how they can use cloud services to innovate and improve the real mission goals of healthcare, things like patient centricity and workforce productivity. AWS, you may know, is the cloud services arm of Amazon. So just going to the report, I agree with many of the things that Lee and Tracy have already said. I think, as well as acknowledging the challenges that the NHS is facing, I thought the report also did a good job of acknowledging the good work in innovation that is already happening in many parts of the NHS. Many of our customers are innovating and developing some new and innovative solutions. It was obviously really welcome to see a renewed focus on the need for more investment in technology and digital tools. and also the recognition that these tools will really genuinely help drive productivity of staff. We know there's a huge challenge with increasing demand and challenges recruiting staff, and the number of vacant positions in the NHS, including in very specialised areas such as radiology and pathology, and looking at how we can use artificial intelligence, for example, to help improve the productivity of staff, allow them to spend more time with patients and families and less time on routine work or tasks which can be prioritised by AI solutions, for example. I thought, I agree with Lee actually, that it was really good to see that focus also on re-empowering patients and creating a very patient-centric organisation. Customer centricity, from our perspective, is the most important part of what we do. We regard ourselves as the most customer-centric, customer-obsessed organisation in the world, and we'd love to help the NHS also create that orientation around the patient and put them at the centre. Because I think when you put the patient at the centre of care and you integrate the different care settings and create new models of care focused around the patient, it not only improves the patient experience, it can improve outcomes, and also it takes a lot of the demand away from patients. And I think finally, I'd just say that it was also really good to see in the report an emphasis on health equity. It's another big focus that Amazon has taken and AWS have taken in recent years. We have a global health equity initiative which seeks to invest and fund good ideas in innovations coming from healthcare providers and helping them build and realise those innovative ideas. So those are a few of my sort of takeaways from that report.
Thank you, Andrew. And finally, Dan, can I come to you next, please?
Yeah, thanks, John. Dr. Dan Bunstone. I'm a GP in Warrington, which is in Cheshire, Merseyside. Clinical Director for Warrington Innovation Network, and also I'm a health strategy consultant at BT. I work in Etc., which is their incubation arm. We've just created an app where it enables people to better manage their health, so gives them real honest information about the big lifestyle changes that can massively impact them, while also recording into their clinical records too. So hopefully living and breathing the some of the information that Darzi's talking about. Fully agree with everybody that's already been ahead on the panel. I guess the bits that I would pick out are Lee's point around, I wonder that we've been here before, talked about this in a slightly different way, and not done enough over the last 5, 10, 15 years to get to this point in time. As an organisation, and I mean NHS when I describe that, we have probably been talking about left shift for far too long and not got on and done it, and it's still super difficult to do that. You try and do that left shift, talk about it, everybody loves it. Trying to do it, 10x hard when you get to that point in time. And actually that shift into primary care too, of course I'm primary care, so I'm conflicted, but all the reports you look at, whether it's Confed, whatever that thing is, it talks about all those things already, shifting into community, shifting into prevention, shifting patient care. I do love the piece around patient empowerment. I don't think we give our patients or citizens, whichever way you look at that, enough, and I'm going to use the word responsibility, to manage their own care. Support when you need it, but not everybody needs the same level of support to get there. I think with really clear advice, and social media doesn't help with this, people can really do things for themselves that doesn't require any nurse or doctor input at all. I think we could really leverage that in an entirely different way that I think Darzi nudges towards, but we could do more.
Fantastic. Thank you, Dan. Tracy.
Yeah, just on what Dan was saying, I think this has been covered by both Lee and Andrew around patient-centred delivery of care. I think there's a risk of a digital exclusion for certain vulnerable populations, so we do need to make sure that we're patient-centred through our digital tools, but develop inclusive technology that's accessible to patients with disabilities and low digital literacy and language barriers. So we need to remember that in our designing. Also, alternative care pathways for those who are unable to, such as those patients already mentioned, or unwilling to use digital tools, ensuring there's equity. And I'd suggest things like community-based digital health programs to educate and support, or even where we have access to digital hardware for patients, they often don't have the tools to actively participate in their care. So empowering them with those apps, such as our app or the app that Dan described, and portals to give them access to their medical records, book appointments for themselves, change appointments for themselves, allowing that flow of data and have access to all of their information, and use the information from their wearable devices and have remote monitoring devices being able to collect data from the home in real time from the patients to the clinicians, enabling patients to be much more active, but also the clinicians to get information outside of the hospital.
Thank you, Tracy. And I just want to ask the audience a quick question as well. What stood out to you in the report? We'd love to hear your views. Was there anything different that you would like to highlight? Feel free to share your views in the chat. So we've covered this slightly, but let's lead on to the question of, what do you think? How can we realise the ambitions in the report? So Dan, you mentioned there's lots of challenges and it's going to be hard, but how can we take steps forward to realise those ambitions? And what are some of the challenges that need to be addressed? Perhaps what needs to be addressed in a short term to get there? Lee, can I start with you for that question, please?
Yeah, so challenges, and let's start with the short term. I think being clear on where we need to invest and where we need to start the journey, and finish off the work that's already been undertaken. And the reason I'm saying the completing the work is, over the last 6 or 7 years, I think every year to 18 months, we've had a completely different 180-degree change in where we invest. Are we doing it in shared care? Are we doing it in EPRs? Are we doing that as exemplars? Are we doing that across the piece? Are we doing levelling up? Are we focusing on cyber? Challenge around all that is, all them are priorities, all them are necessary if you're going to have an effective digital infrastructure. But the issue is doing them all at the same time and having a short, medium, long-term plan. So the key bit for me in the short term is really to tie in what we're currently doing and make sure that ties into the 10-year plan. And I think the 10-year plan is going to be key to that work. Short term as well is on the development of that 10-year plan is the involvement of suppliers, involvement of the people at the front line, on experts that are not just fixated on NHS England as well. NHS England are very good at looking at themselves. They're not a good representation of our patient population. They're not necessarily a good representation of our frontline staff. So the best way to get that is get that diversity and understanding from them. By doing that, I think that answers the other side of the question, is where do we invest and where do we go? Because at the moment, I think I would prefer to have that understanding from a wider engagement, carrying out some level of user-centered design, carrying out some level of where is the best experience, and less about a minister has said, actually, it'd be a really, really, really good idea to implement this system because I've seen it in one trust and it's brilliant. We're going to implement it across the country. And historically, that's happened too many times. So, use the short term to get that consistency, to get the medium term, long term plan, get the long term plan, have that longer term investment. Stop the silly, because we've got it at the moment. Here's a load of frontline digitisation money. I'm sure any NHS body will have had that from fed over the last few days. Can you spend it by the end of the year situation? It's November. What a surprise. I think I've been in the NHS 20 years. Comes to November, we've got capital spend. Smart money would have already have business cases ready. We shouldn't be in that situation. So, John, I think I've sort of waffled slightly off piece there, but hopefully that gives a view of what I would say.
Yeah,
and don't get me wrong, that engagement takes time and effort, but without that, we'll still make the same bad decisions that don't focus around people in care and what's important to them. And I will come back to social determinants for health. A lot of people don't see health as their biggest priority. Even if they're going for an appointment, their biggest challenge is, where do I park? How long is it going to take there? Who's going to take me? Where is the damn place when I do arrive, if I haven't been there before? And why do I have to go and spend to just do that for 10 minutes? Now, that's an old-fashioned approach. Obviously, we do need to move into the 1990s or even the noughties in health to improve on that, rather than all the health information that comes, which, to be honest, for a 10-minute consultation doesn't require necessarily a face-to-face. Sorry, digress somewhat. So hopefully that sort of rounds off my points and then hands over to the next person, John.
Thank you, Lee. That was great. And Tracy, can I come to you next, please? The same question, what are the challenges and how do we address them? We've also had a question or a comment in the chat around, I think interoperability was not mentioned much in the report, but it's a massive pitfall. So keen to know your views on the interoperability challenge, as well as how do we realise some of those ambitions in the report?
Mm-hmm. Okay, so main challenges and how we can address them for me, we've covered integrated care and I'd say to a degree interoperability, but one of the report's goals was integrated care and making that seamless connection between primary, community and hospital-based solutions, or as Lee said, between solutions within the hospital, so that making those solutions interoperable. This integrated approach, I think, is essential for creating that visibility of information across ICSs and regions, and ensures all members of the MDT, regardless of location, have access to up-to-date information about the patient's care journey. And this is especially important for patients with complex and chronic conditions, or those that require services in multiple areas. So as a supplier, I see that as being supported by open standards, which I have repeated, digital platforms enabled by terminology service, so that you don't just have data, you have data that's shareable. And Lee, you mentioned NHS England, and I'd say as a positive point about some of the work NHS England's doing, Helen Basildon's leading some standard work with nurses from across the country on nursing documentation standard, which I think is really
stuff,
important.
Tracy, yeah. As
Some
a
really
member of the
stuff.
PRSB advisory panel, I'm totally aware. So, but again, they've had to ask a third party to do that, Tracy, which is fine. Completely get that. And Helen's brilliant. I do think Helen's wonderful, but I think the issue is sometimes that's the exception rather than the rule, Tracy, from my experience on digital. Sorry, Tracy, for
that's okay. No,
yeah.
I think
Helen's stuff is brilliant. The PRSB are a really good body. And they're the type of people that can help that piece. So fully agree with you, Tracy.
Yeah, absolutely agree. So I think you're right, and also there is some good work being done. So the work that Helen's done on documentation standards, I think, will really lead the way in terms of improving safety and patient flow. And as you said, the PRSB standards, the Get It Right First Time programme, all being led by clinicians, all leading to standardised approach to data and information, which can be used. And I really, really strongly advocate for those being adopted by software solutions and incorporated into their standard content. I think we need to also prioritise cybersecurity and data governance. There's a lack of trust for reasons that are very valid, given there's been recent data breaches across the NHS. So I think we need to strengthen cybersecurity measures, protect patient data and build trust in our digital systems, ensure that we are compliant with GDPR and NHS data security standards to foster that confidence across stakeholders. And we can realise some of the challenges by enhancing, and I did mention it earlier, but just I'll add to it, patient flow with real-time tracking and automation. So we know that there's bottlenecks in admissions and transfers, and especially in discharges, which disrupt patient flow through the hospital and out and into the hospital. And having an ability to have real-time bed management systems to monitor availability of beds, speed up that patient transfer, and automate discharge planning by integrating clinical systems, and having something as simple as auto-population of different documents throughout the solution. So if a clinician has completed a document, rather than having to duplicate that effort and write the exact same information in another form, have that data flowing through, so that by the time you get through to your discharge summary, a lot of that is already auto-populated with relevant information from the admission, making sure as well that you're surfacing data to the clinicians in a really usable way. So having dashboards where you can see at a glance the most important clinical information about your patient, or being able to see information relating to all of your patients at a glance as well, and being able to identify bottlenecks and your workload for the day. So we're going into there maybe a little bit more than just a clinical, but maybe a system overview where you might have information such as you'd get within a command center that's actionable as well.
Fantastic. Thank you, Tracy. Dan, can I come to you next, please? What's your perspective on what we've spoken about so far, and how do you think we can realise those ambitions in the report?
Yeah, it's a really good question, John. So I think the NHS broadly suffers from the innovator's dilemma. And what do I mean by that? Where we have a situation where we focus too much on the now and not on the next. Great example of that, if from industry, is blockbusters and Netflix. Spend a lot of time working out on a bit of kit that will make your VHS rewind faster, but completely losing focus on the other things that are going to make that real difference and really shift the market. My NHS example there would therefore be focusing a lot on A&E attendances and people getting to the front door, and nothing at all or hardly anything at the left shift, at prevention, at what we do to stop people falling in the river, to mix my metaphors massively, but quote Desmond Tutu at the same time. Tricky maneuver, that I can tell you. So what do we do? Alexis has made a comment in the chat group that's absolutely relevant as well, where she will talk about investing for in year and then not realizing the benefits and how you achieve that. I think as organizations, we, and that's probably a little bit higher up the food chain than me, need to be brave in what we do. Yes, we definitely need to help our current level of patients, no question around that, but we absolutely have to focus on what next might look like. I've said before in previous talks, we talked about left shift and prevention and digital 10 years ago and just haven't done anything like enough. We definitely can't be sat here, all 5 of us 10 years older, having that same conversation. We'll have gone down a plug hole by that point in time, health system. And we see this across the world. It's not just the NHS that suffers this. It's a worldwide phenomenon. Everybody's suffering the same problem. So everybody's wrestling with it. It's not just an NHS thing, but we have to do something. We have to be brave around allowing things to temporarily fail before they can succeed. You need to enable that J curve to happen. Things can't be successful. They might be, but things don't unicorn overnight. Daedalus, I'm sure, did not. Amazon, I know, didn't. Massively successful businesses to quote where we are now, but they will have spent time and money investing to get to that really successful position they're at now.
Thanks, Dan. Andrew, can I come to you next, please?
Yeah, sure. Yeah, and I agree with Dan, actually. I mean, we consider sort of success and failure to be inseparable twins. So you have to be, if you're not failing occasionally, you're not trying hard enough, in a sense. In terms of where I think the challenges are, I mean, sort of over the course of my career, really, the challenge at the beginning of my career was the technology itself and building new innovative solutions. So the challenge was technology, but it's not anymore, really. Cloud solutions now can be built in weeks. You know, if we cast our minds back to the pandemic, the Test and Trace app was built on AWS in 12 weeks. It got medical device regulation covered, and it was launched, and it was scaling to tens of millions of people within weeks. So the challenge is no longer building the solutions, because we have technologists and we have partners like Daedalus who can build innovative solutions using latest technologies really quickly and in a really agile way. I think that means that the challenge has shifted now to being much clearer on prioritization and deciding on what you're going to build. So one of the processes and techniques that we use at Amazon and AWS when we develop any new solution is we work backwards. And I think a lot of the other panelists have mentioned this, which is you really need to identify who is your customer, who is the person you're trying to solve a problem for, what is the problem that they have, and what is the solution's most important benefit in solving that problem. So taking that approach and spending a lot of a good amount of time at the beginning of the process to make sure you're building the right thing, I think is really important. The other thing that we've seen amongst our customers who are innovating really effectively and in a very agile and rapid way, is that you get alignment and commitment of the leadership, and you get top-down goals in the organisation which drive innovation. And that really helps people be clear about the needs and the demands of the organisation on them to develop new and innovative solutions and, you know, take risks and think big. The other challenge, I think, is digital skills, and we're putting a lot of effort into improving the digital skills across public sector organisations, including the NHS, because that's really important to unlock the ability for people to develop and procure new and innovative solutions on the cloud. And I think the other thing to remember is it starts small, and as I said, think big. You don't have to boil the ocean when you start out on this journey. You can start on a very small area, develop something new and innovative. When you've demonstrated success and you've proved that approach works, you can then start building on that, creating your version 2 or 3, or going into other areas, identifying other problems for other people in the system. And so, you know, we love to start small with organizations, but then really have a big vision about it.
Excellent. Thank you, Andrew. Okay, right, we'll move on to the next part of the session. I'd like to talk about how we move from a diagnose and treat model to a model on prediction and prevention. And we've spoken about this slightly, but how can digital play a role in that change? And how can we better choose interventions based on stronger evidence? Like how are you doing that in your area, Lee? How are you planning to move towards a prediction and prevention model, and what interventions are you choosing?
Okay, so in our region, in my area, we're looking, we're sweating. Yeah, I'm not being, you know, it's not AWS, I'm afraid, Andrew. It's Azure. We've got via Next, and there's I mean, it's a standard. It's cloud-based. So again, I'm talking tech. What we've got is all the data feeds that we'd normally get for HES, mental health data set, IAPT, community, that type of stuff. Put it all in a big data warehouse, do some good old-fashioned data mining. Yet to really move, I would say, into the data lake AI environment in there. So that's just what we've got. Data quality, yeah, there's a maturity index that says it's really good quality. But again, it's only good based on how you determine that. So if you're looking at it from an NHS England counting beans point of view, it's okay. If you're looking at it from how do you assess the health of the population, we're still missing a number of determinants for health. So, you know, getting education data, for instance, is always a good indicator. How we bring in any, police and or fire, how we bring in social care data, social care data. And in a lot of cases, all these other, or even just lifestyle data, there isn't a lot of standards around these data. So I know we're saying about open standards, Tracy, and I'm fully supportive of open standards. Really do get them, but we do have a lot of gaps around open standards. And if we're then going to analyze and utilize that data to help either digital twin, run that simulation based, or understand the population needs, it can get quite difficult if we don't have something to actually measure against. Because are we apples, oranges, bananas? That type of thing. That's when it becomes a bit of a challenge. Now we have in the region of working, we have got the Born in Bradford team that have done a lot. It's only around 1 million population, but they have cracked a lot of that nut around linking all that data together. It's well worth having a look if people want to go and have a look at the Born in Bradford data. It's all on the web. It's all really interesting. There's a lot of open information there. But again, they've had them same challenges of how do you link, shall we say, the early education data, because it has been running for 20 years, this data set, and how's that influence people's, quality of life and issues there. So, you know, there's a couple of different extremes there. I'm talking Humber and North Yorkshire with the, shall we say, good old fashioned. Bradford is in West Yorkshire, so what they've been doing. I think the real challenge isn't necessarily pulling all the data together. The AI could have a place in there. It's just how we train and how we tweak and get the learning around using AI. I'm just looking at some of the chat stuff that's coming through. So is AI a panacea? No. Could it be a panacea? Maybe. Still quite an emerging technology. I did put something in there earlier. So we are using that to then focus in our area around cancer, mental health, especially around children's. It's a major issue. That requirement has grown significantly, and we're having to be a lot more, shall we say, imaginative. So, for instance, we did just as a real different example, we've invested heavily with the service on user-centered design in the CAMS and children's division with technology. So we've worked with other vendors, SMEs and suppliers that's been able to reduce our waiting list from 4 years to 6 months, for instance, for ADHD, which anybody who's in that world knows that's quite good. They actually won a HSG award as well, but I know that's a different media place, so I won't press that one too much. But that did require a lot of different thinking. I did think that division was quite good. That division's also done a lot of co-development work with the LD service and children's of how to engage and communicate effectively with them on what's important to them. So sorry, I'm sort of going off tangent, but the data sort of said there's a particular area we need to focus on. We've done some very specific pieces of work. The issue we've probably now got, just as an example, John, I guess, is how do we spread that? How do we not go through the same pain in every ICS or every region to reinvent all them different wheels of, you've got a change in approach around children's, ADHD and CAMS, children's mental health waiting lists, different ways of working, in reaching to schools, using technology, working with the families. I'm sure we're not the only people that do that. I'm sure it's all over, but we're very good at all developing our own solutions and then and not necessarily spreading that learning. Now, if you was in a corporate entity, the chances are that corporate entity would force that spreaded learning. We don't really have the environment that forces a spread of learning, or if they do, it doesn't quite happen, or it doesn't quite last long enough. It might be. Rakesh, if you want to come back to me, I know I owe you a couple of emails actually, mate. I'll pick it up because I can link you in with the operational services around that one. I'll answer in the chat. Sorry, John, I've gone off on one.
No, fantastic. Thanks,
so variable data, we've got some really good data sets that's siloed. We're trying to expand that as part of the SDE. Some that's fairly minimal. We have got development based on that sharing. That data again, it's down to spread out, so it's, and then there's the final important bit, and I know I haven't touched on it, but it is all about the cash. If you don't have money, you don't have cash.
As well, I've said the same about investment.
Yeah. Oh yeah, Joe. Well, Joe definitely will. I know Joe well as well. So, and Joe's very, very knowledgeable on the cash stuff, far better than me. Yeah, just send us the cash, John. Is that John Quinn, Joe, rather than John Wilson? So, but the cash is important. The NHS gets fixated, on cash, that if you put money in to do development, the business cases don't seem to ever get the savings out. Commercial entities, if you did that, you'd just kill the damn thing. You wouldn't carry it on. But in the NHS, we carry on and we run old-fashioned processes with new processes too often. It's really good when we do, but we'll carry on running a 1980s call centre in parallel with a digital communication solution, and we'll be too scared to actually drop down to just do the digital with some workarounds for people that have got some level of restriction. So you still man up that call centre or resource up the call centre rather than moving to new ways of working. So that's another challenge. We're not very good at accruing savings, whether they're cash releasing or non-cash releasing, and then benefiting from them in a lot of cases. We're very good at taking money, very good at saying we're going to do something. We're not very good at them benefit side. Even qualifying the qualitative benefits. I must be honest, if there's no quality benefits, we shouldn't be doing it. Quality reduces waste, it improves productivity, it's a known link. We do not need to reinvent the wheel on that one. but we get fixated on different things. So sorry, John, again, I've gone off on my normal one where I'm not really paying attention.
Thanks, Lee. So Tracy, can I come to you next? The question around how can digital support focus on prevention, but how can that be looked at from an ICS region perspective? Is there a need? Is there a data need? How can that be translated into making an actionable move to preventative care? What's your view on that?
I guess, as Lee said, he mentioned, and I've mentioned open standards, and I think he's absolutely right. There's different standards, different solutions. That means that sometimes it's not readable and not shareable. But I do think terminology server can help here to a degree. So we just need to make sure that we have those shared care records and the data platforms to be able to enable that data to be readable and usable. And also, when we, as clinicians, we're completing our clinical documentation, we're often guilty of trying to find the easiest possible route in terms of our documentation, and that means that sometimes we're not completing data in a way that is going to be usable. We're not able to then see that data in predictive analytics. We just have free text, so we need solutions that are able to look at pulling codifiable information from free text. We have clinicians that are using data in the most streamlined ways possible, and that we're able to surface data from acute through to clinicals and back. We have some solutions, I think, which are really, really helpful. We've mentioned the patient app, which is really important, but also having the ability to work offline and then have that at the point of care information, so clinicians aren't having to document in the community and then go back online and retranscribe that information, that actually they can put the information directly into a handheld device, and when they come back into the hospital or they have some connectivity, that automatically updates the solution. So I'd say for me, that would be how just supporting the data flow and supporting the regional view. So you have the solution supporting both acute and community care, patients and clinicians having access to the same information.
Great. Thank you, Tracy. And Dan, what's your view? How can digital support integrated care from a wider regional perspective?
Yeah, so I think I've got a pretty live example actually of using digital and prevention. So we looked at nothing particularly complicated. So we took all our known hypertensives who were known to have high blood pressure, but then not sufficiently well treated for a whole host of reasons, collated all those together and actually supported that population to improve their blood pressure. The reason is it was, I'd say simple, but it's a simple piece of data you're getting there. There's nothing complicated around that. You share it across practices, and we know these patients are sat there at risk already. Managed to treat around 650 of our patients to target, reduced their risk of heart attack and stroke by around 3%, which means saving 18 heart attacks and strokes and about £750 to £1 million to the economy at a cost of £100,000. The reason I highlight that is it's not really bells and whistles prevention PHM stuff, but actually it's effective. It starts paying back money relatively quickly for the system, which is what the system needs. And of course, you can see a 5 or 6 to 1 return on investment there. I think we can sometimes get a little bit tied up in creating massive data when actually, if we start small, it's a reasonable route to take. You do relatively small projects on relatively small data fields rather than data lakes. And of course, you can then show the benefits of doing that rather than going too big too soon. So I think we went quite small, quite linear, but have got pretty powerful results.
Great, excellent. Thank you, Dan. Andrew, from your perspective, what's the role of digital in realising integrated care and taking a step towards that?
Yeah, absolutely. If I could just quickly go back to prevention as well, because I think there's a real important issue when we look at scaling prevention programs, which are so important. As a GP, when I saw patients, almost everything you did was a kind of scale of 1 to 1. You could see one patient at a time, write one form at a time, write one letter at a time, request one investigation at a time. And the rest of the health service tends to work in a similar fashion, that you need more staff to deal with more patients. What we've seen is that when you can really clearly identify cohorts of patients, and this particularly applies to prevention, with similar needs and similar services required, you can actually create digital platforms for some of those people in order to help, use those services in a much more agile way, which brings the service to the patient rather than the patient having to come to the service. And we had one partner called Armada Health. They created a diabetes prevention program on a digital platform. So instead of the patient having to go to a nutritionist and someone to give them advice on exercise and a coach and their GP and a nurse, they could actually access all of those services on this one platform. And of course, then they could interact with other people who are also on the platform, so they could get other patients and people who were in the same situation. So there was huge advantages, but they still had the opportunity of having a one-to-one with a coach if they needed it. So I think that's really important. I think the other thing about integrating care is the better use of multiple channels. And I think Tracy mentioned earlier, very right, correctly, that we've got to be careful that digital innovations don't exclude parts of the population. But one area where we saw it almost did the opposite, actually, was with breast cancer screening in North Midlands NHS Trust. And what they did, they created a Facebook campaign for breast cancer screening. And as a consequence of that, breast cancer screening went up 16 to 17% within that area. And one of our partners helped create a chatbot on AWS so that people could ask questions 24/7. How do I get to the unit? What do I have to bring with me? How long will I be there? When will I get my results? Those kind of things. And it just, just introducing that channel, that social media channel, actually accessed a group of patients who weren't responding to letters from GPs or other means, SMS texts, for example. So using the channels which people are most comfortable with allows you to create services which inherently and intrinsically integrate the service around the patient. So I think that's really important.
Excellent. Thank you, Andrew. And Lee, can I come to you for that question as well? How do we realise digital integrated care?
So you realise digitally integrated care by not realise it's actually happening. So, because you don't have the handoffs, you don't have the pain, you don't have the, I've got to enter data on top of my day job because the system is not built in a way that supports clinical practice or administration processes. I know we focus on clinical, but admin is just as important in the setting to make sure we have the right people doing the right job at the right time. So, my view of knowing it's effective. Now, that's the way I would see success, John. To do that success is extremely painful. It's long term and it requires a different mindset. And it does require organizations to move from silo-based to the integrated care approach and focusing around patient. And I sort of say that semi-tongue-in-cheek. Anybody who lives on the border between England and Wales, it must be an absolute pigging nightmare if you're going to get your prescription in Wales, but your GP's in England, because them systems do not link, for instance. So, there is a wider, whether we talk England, Scotland, Ireland and Wales, or whether we're talking the Great Britain, or we're talking, so it does make a difference. I think personally there's if we have staff that feel the systems help them do their jobs rather than stop them or make it harder to do their jobs, if we have patients and the public that actually find it really easy to access our services, as they would do by going on Google and saying, I'm going to go to, I don't know, I'm going to go and check what's on the Black Friday deals. I know that's probably one people might be looking at the moment, as long as they don't get any phishing attacks based on that, of course, because that's always a good one for phishing and cyber. You're not going to go to every website. You'll do a Google search. So why don't we have the same type of approach? Why don't we just do what the rest of the world does, rather than think that the health is different, rather than people just use technologies the same way? But all that, to be successful, does need to be underpinned by everything we've talked about, either the barriers or the innovation. So For the underpinning systems to improve, we've got to go to open solutions, open platforms, separate data and application layer, have an agile way of developing the applications, because clinical practice change regularly. A 1 or 2 year, an annual or biannual update on your software is not adequate. Practice might well have moved on in that period of time, or practice has varied, as we've seen in a lot of mental health services. Changes and also just that integration. So we're still in the world. I mean, we do say commercial. We'd like to be where open banking is, I think, for information sharing, because that seems brilliant. Although I would probably, if I was in a room, I'd probably ask how many people on their Barclays app or Santander app actually bother looking at the other bank accounts in that app. Just because I'd love to know. I mean, I tried it once and found it was a bit of a faff, and I'm just happy to use the 2 apps. Yeah. For instance, just because of different functionality, just go with me on that one. The other side of it is we've got to remember the NHS is a bit like where we are at the moment, and it's not probably quite a good analogy, but it's getting there. Is we're putting our order into so if it was shopping. This is the NHS from shopping. Sorry, John, I'll shut up after this one and hand over, because I know we've got 10 minutes and Lee's gone off on one of his rants again. What we've got in the NHS, and this is where we don't want to replace an experience. It needs to be slicker than this. I'm going to place my order on Asda from a shop, and then I want Sainsbury's to deliver it, and I want Tesco's to deal with all the issues, and I want Morrison's to deal with the payment. That's what happens in the NHS, because they're all separate. They're all little organisations. They're all different bodies in that way, and they all have different information governance issues. And final bit, John, and then I will shut up. Is it's absolutely essential that we get the act through, the new Data Act through, that will mandate the interoperability between systems, albeit there's still a regulation level that needs, because act with no regulation is a waste of time. As we know from the 2012 Act that mandated the use of the NHS number, and it's a legal requirement, I think I'm still struggling with some organisations to really consider what an NHS number is, even though they're legally obliged to actually follow it. So the regulation is actually key. I'll give NHSE the due on that one. I have been involved in a number of the workshops, and they really have put a lot of thought into that regulation aspect. Albeit it's gone a bit quiet because now we've had a re-election, everybody's looking at different money, and so yeah, that's sort of my wrapper on that one.
Thank you, Lee. Excellent. So we've got a few minutes to go. So if anybody in the audience has any questions, type them into the chat, and we've got a few minutes to ask them now. I've seen lots of great comments, so thank you for those. Just quickly then, to pull it back to the Darzi report, could I ask the panelists to share one thing that they would like to see change, or in the short term? What would you like to see happen in the next year or two, whether it's coming from centrally, NHS England, or what would you like one thing to change in the short term in relation to realising the report? Andrew, can I start with you for that question, please?
Yeah, I think what would really help is if we saw people within the NHS really feeling like innovation and change is possible, because it starts with that, really. I think it's really important that people recognise how straightforward it is now to develop and design your own innovations, digital innovations, launch them and scale them, go from pilots to real productionized solutions, and really help those organizations share the data appropriately in a very secure and privacy protecting way, but enable that increase of data liquidity across the system. We've talked a lot about patients moving across the system, having services integrated around them, and then it being a much more patient-centered service. But that data needs to follow them. So the ability of services to be able to use the data that's held in electronic patient records and other services, access that data for new and innovative tools, so that people can really innovate more quickly and in a more agile way using the data that's already available around that patient. I think that's a really important point, and I think, you know, just for people to realize that, you know, these innovations are within reach. They need to be really clear about what their priorities are and what problems they're trying to solve. But once they've got to that point, you know, it really, you know, we want to see them innovate quickly in an agile way, and deploy it and take it to their region really quickly, and then nationally potentially as well. So those are kind of some of the things that I think are big priorities coming out of this report.
Excellent point. Dan, can I come to you for the same question, please?
Yeah, for sure. Extending what Andrew says, I agree. We've got to get to a point of rollout. So I think, going back to my previous point, we need the system to be brave. And I'm not asking for £10 million, but I might ask for £10,000 to do a modestly small project that will have an impact, and then commitment to invest into that later on and enable it to fail too. There are a whole host of things that we can do that isn't overly complicated, wouldn't turn people off, and would have a huge impact for our patients too. So be brave, start modest, and commit to investing at a future point in time.
Excellent. Thank you, Dan. And Tracy, what's your perspective?
So I'll briefly go through.
Good.
I'd say adopting virtual and hybrid models. So we're still really reliant in the NHS on in-person consultations. Mainly, I know that some areas are really adopting the telemedicine, but the in-person consultation reliance leads to delays and inefficiency. So we really need to scale up the telemedicine and virtual consultations to reducing the outpatient backlog and improve access. So giving patients the ability, as I said before, on their apps to be able to choose between face-to-face and digital, depending upon their needs, obviously, and then linking that so they have the ability to communicate back to the care teams. And I think quickly, we need to deploy AI and data-driven solutions. So there's too many manual processes and lack of predictive insights at the clinical coalface, as well as at an administrative level. So clinicians are enabled to make decisions quickly because they don't have that information there. And we're talking about, as Lee said, even patient demographic information if we don't have the right patient identifier. So GS1 standards being something we can adopt to help there. So we need to use predictive analytics to forecast demand, that's sort of a bit future, and optimize resource allocation in the way that Dan said, and implement AI-driven triage tools to be able to use those tools for AI and prioritization for A&E, and employ machine learning to streamline administrative tasks, so utilizing ambient listening and natural language processing for some parts of the administrative tasks, so that rather than after a consultation having to go and document, that information is already within the system, and you can flow through your software solution through your voice rather than having to go into the computer. And one very, very last simple thing is improving the usability and the UX within the solution. So making, as Lee said, we have these really great social media apps which are really usable, and on the whole most of the EPRs and software solutions are still very click heavy. So if we make sure that we have digital solutions within healthcare that have a really good UX and UI for the clinicians, where the data is serviceable to them in dashboards, and they have reusable data. So once they've input some data, it will automatically throw through the solution and they won't have to duplicate effort. I'd say that's something that we really need to do, and it's quite easy to do.
Excellent points. Thank you for that, Tracy. And we've got a minute to go, Lee. Can I come to you?
No, I guess you left me last, John, so everybody. So mine's really simple. What is NHSE going to say we can stop doing to create headroom? So everything we said is great, but without creating headroom, and normally you'd run organisations with 10 or 15% headroom to do innovation, R&D at least. We don't have that in a lot of the health sector. You know, we're absolutely maxed out. We're getting resources in. So what can we drop? So in Andrew's example, that's great. Can I stop doing contract reports, which takes 60% of my analytics staff that goes to people that don't really need contract reports and doesn't add any value to care? From an AI point of view, you know, if I've got headroom, I can start putting some resource into AI and start really getting into it and make sure we have got safe systems rather than the snake oil that some AI companies are selling at the moment. And there is a lot of them that want to talk to you all the time. Well, there is, based on the number of FOIs I get every week from from people asking about AI. And it's to be brave, but that's by being brave. Let's reduce. Let's agree we can stop doing something that adds no value to patient care or professional or quality, and then let's then move on. That'll help create that capacity for the next steps. Without creating that capacity, we'll still be having the same conversation in 2 years' time.
Excellent. Thank you for that, Lee. And I'll look to close the session here because it's just turned to 12 o'clock. So the session has been recorded. We will do a write-up of the discussion points, which I think will be a really key document, actually. So we'll share that too. I think that'll be really valuable. But I'd just like to say quickly, thank you to everybody for joining, and thank you to our panel for sharing your views and opinions and perspectives. It's been a great discussion today. And it's 12, so I'll close the session here. Thanks, everybody, and have a nice day.
Thank you.
Thanks. Thanks. Bye.
Bye-bye.